Good morning and welcome, everyone. Is everyone excited for the last day of Summit?
You represent Boston? I represent Cape Cod.
A little excited. That's all right. All right, well, I am excited about this particular session because I have been with NCSL since 2018, covering issues related to substance misuse and overdose prevention. And every year when we have a session like this, I get to tell you how it has actually just gotten worse despite everyone's best efforts. But this year, excitingly, we actually have some good news in the overdose world. And so we're really excited to share that with you all and hear from our really fantastic speakers and panelists that we have with us today. So to blueprint what this is going to look like for you all, we will first hear from Dr. Allison Arwady, who is the Director for the National Center for Injury Prevention and Control at CDC. She leads CDC's data, prevention, and response work to overdose, suicide, violence, and injuries, the leading causes of death for Americans in the first half of life. Dr. Arwady previously served as the Commissioner of the Chicago Department of Public Health, leading the health department of the nation's third largest city, including through the COVID-19 pandemic. Prior to that, she spent 4 years as Chicago's Chief Medical Officer, overseeing the department's behavioral health and disease control work. Today, Dr. Arwady will share some of those insights on these exciting declines in overdoses and discuss what CDC is continuing to do to address the overdose epidemic while overdose rates still do remain unfortunately high. We will then have a brief panel conversation where I will bring in Delegate Matthew Rohrbach of West Virginia. Delegate Rohrbach is the Speaker Pro Tem of the House of Delegates in West Virginia, and since his election to the House of Delegates in 2014, has been a leader in addressing substance misuse and overdose. I'll also bring in Senator Julian Cyr, who is the Assistant Majority Whip for the Massachusetts Senate. Senator Cyr represents the Massachusetts Cape and likewise has been a champion of overdose prevention since his election to the Senate in 2016. I do want to note that at the end of our conversation today, we will have an opportunity for Q&A. You'll note the 2 microphones there towards the middle of the room, and we'll sort of prompt you all at that time if you'd like to ask questions. If we don't get to everyone, I do also want to flag that we will have an office hours with Dr. Arwady following the session at 12:15 p.m. We will meet in room 109, so I know that's a little bit of a haul, but we hope you will join us for there at 12:15 if you'd like to engage in a little further conversation and deeper conversation with Dr. Arwady. But with that, I'm going to go ahead and turn it over to Dr. Arwady, and we'll dive into these declines.
All right, thank you so much, Charlie. It's such a pleasure to be here. And I really want to start by saying thank you to everybody in this room. Because if you have come to NCSL and you have chosen to come to a conversation on this topic, I know you are my people. I know you are as concerned as we at CDC are about what is still the leading cause of death for Americans between the ages of 18 and 44. And you are seeing with us some real signs of hope and progress. Thank you, NCSL, for having us. The Injury Center loves to partner here, and some of the work with the Opioid Fellows and others we think has been just incredibly important, innovative work. And at CDC, as you heard, I spent a long time really at the local level before coming to CDC about 1.5 years ago. And we know that so much of the innovative policy work on overdose and so many topics starts at that state level. So thank you, and we have a lot of work to do still. You can see, as we talk about the evolving overdose crisis, we really do frame at CDC our work as supporting states and local communities. That's what we see our role to be with a data to action focus. So, because data is the love language of CDC, I'm going to put some data up. We'll share this around. You can take a look later. But very high level, I know people in this room know this, but I want to just highlight what the last 25 years have looked like for overdose in this country. Those green bars show us overdose deaths in the US from the year 2000 through 2024. And I want to remind you that as recently as the year 2000, we had fewer than 10,000 Americans dying from opioid overdose. And then we peaked out at opioid overdose, you can see during the pandemic, at over 80,000 a year. But look at that data from 2024 and that big drop. We are seeing real progress, and that's what I want to highlight. We also highlight here in the three graphs running over the top. That first one is about the first wave of the opioid crisis, which was all about prescription opioids. That's showing you that blue line, how we got up to a point where about 75% of opioid-related deaths in this country were due to prescription opioids. Then as we started to get a handle on prescription opioids with policy approaches, with science-based evidence, we then saw an increase in green there in heroin, some of that transition, lots to learn. But then finally on the right there, the story of fentanyl. And I know all of you know that when fentanyl really hit the US, our ability to stay ahead of this problem was really compromised. We've been working to get ahead of it ever since. Always pictures better than graphs when you're telling stories. And I always share a picture of what a lethal dose of fentanyl looks like for somebody who does not have tolerance. And when fentanyl, as you know, is made in a laboratory, so it's not like heroin. It doesn't start its life as a poppy plant with lots of opportunities to intervene along the way. This is made in a lab. It can be shipped in incredibly small quantities, and it has changed the landscape for us here in the country. This is the good news, though. Since 2023, we have seen a sharp decline in overdose deaths. In fact, our provisional data from 2024 had a more than 25% drop in a single year in overdose deaths. Those of you who work in this field know that we're often aiming for a 5% drop in these leading causes of death, a 10%. To see a 25% drop in a year is an incredible improvement. And we've been working to make sure at CDC that working with all of your states, we're getting faster and using a little more provisional data. Death data takes a while to get finalized, right? Your coroners and medical examiners all around the country have to investigate the deaths. They have to wait for the toxicology. They have to sign the death certificates, particularly overdose deaths, to have more data in them. Take some months. They just do to come in. But we've worked to make sure that every single month now, we are updating our fatality data with a 4 to 6 month delay in it. And so every month, this graph on the right here, we're updating to say, where are we seeing progress? Where do we still have room to grow? Every state in blue there has seen a drop in overdose deaths for the most recent data, February 2024 to February 2025. And you can see the darkest blue states have drops of more than 40%. We still have 3 states that saw some increases over that year out west, but increases of 3%, which when historically what we've been talking about is incredible progress, but still a long way to go. What I think has sometimes not been highlighted as much in the excellent news about the drop in overdose deaths is that this has been part of a cascade. We've seen a drop in overdose deaths. We've seen a drop by and large, although there is some variation across the country, in non-fatal overdoses. So we know it's not just naloxone. We've seen a drop in people being diagnosed with opioid use disorder, although there are still many, many people who are not able to get the evidence-based treatment that they need. We've seen a drop in recreational use, and we've even seen a drop in high school students reporting use. CDC is about primary prevention. What do we do to prevent drug use before it starts? What do we do to make sure that young people understand some of the really changing risks that are present in the drug supply? This is data from the Youth Risk Behavior Surveillance. This is a survey that's done nationally every 2 years across the US in middle schools and high schools. And we see in the year 2013, about 16% of high school students reported any illicit drug use, that's excluding cannabis, in the prior year. And by 2023, the most recent year, that had dropped to 10%. That's a 40% drop. And you can see similar drops in reporting the use of alcohol and a little bit of change there in cannabis as well. But we are making progress on that whole cascade. And I think it's important to think about every step there from a policy perspective. I do want to call your attention again where we've been working to make data faster, more local, more action-oriented. There's a new dashboard that came out from CDC just the beginning of this year, again, working with all of your state epidemiologists, where you can see the most updated real-time data of what's happening at your state level. So this graph on this map on the left is showing not the change, which is the one I was showing. All is blue, working progress. This is a burden. The darker states we're seeing change the most overdose deaths per population. But importantly, this is meant to be very user-friendly, and you can go and click down to the state level, to the county level, and even to the census tract level. And we have this for a range of the topics from the Injury Center. So for injury, overdose, violence, you and your health departments are able to get down to a very local level here. And importantly, we're updating this every month with the most recent data. So would love to encourage you to explore that. We've also been working very hard on non-fatal data. So overdose death is a tragedy. A non-fatal overdose is an opportunity. It is an opportunity to get someone connected to treatment. It is an opportunity to reach their family members. It is an opportunity to reach their community members. It is an opportunity for us to know how the threat is changing and how we change our response at the local and the state level. So we also have data, and there's a QR code that we've also worked. This is much more real time because you don't have to wait for death certificates. So on the ground, your state and local health departments are able to now see same day what is happening in emergency departments, what is happening with EMS runs, and then at the national level, we're pulling it up and pretty much monthly doing some updates of how trends are changing across the country. One important thing is it's not just opioids anymore. I know you know this, but it's really a polysubstance crisis. And so we've worked to include a whole range of drugs in the updated data. I also just wanted to highlight some of the more hidden pieces that CDC is continuing to invest in to help the country try to continue this progress. One is our laboratory work. You don't think a whole lot about the lab, but if you go back 10 or 15 years, we really did not have the knowledge of what was driving overdoses. We knew people were having overdoses. We knew that they were often responsive to naloxone, and so you knew that opioids were likely involved, but we did not have the laboratory infrastructure to do the more advanced testing for both fatal and non-fatal overdoses. So every month, CDC's lab sends out a kit to all of the state laboratories. These are the 2,400 emerging things in the drug supply right now. So if you're in Oregon and Massachusetts has already seen something and it hasn't shown up, we're now testing for it ahead. And our ability to keep that kind of behind-the-scenes infrastructure up is critical, again, to continue to adjust our responses and drive it down. CDC also, and the Injury Center, have been really pleased to support states and localities in what are called epi-aids. In case you don't know, any of your states or tribes are able to request free on-the-ground support from CDC. We send epidemiologists and scientists out when we're seeing something unusual in the drug supply. We had one here in Massachusetts last year, for example, with xylazine. That's a newer contaminant in the drug supply. It's a veterinary tranquilizer, and people were getting, they get unusual wounds. There's different presentations. We've got some going right now with medetomidine. We come and partner with your health departments, in part to make sure that as we're learning more about the changing threats, we can then lift that up and share that with states across the country. I do briefly want to highlight that this keeps changing in other ways. It's not just the drug supply. One thing is that it's no longer injection drug use driving most of our deaths. It's smoking. And typically it's smoking still substances that include fentanyl, but if we are not continuing to change our outreach, our policies, our approaches, we have to continue to focus, of course, on injection drug use that comes along with all of the risks related to infectious disease. But especially for young people who may not think that smoking carries risk, this is the kind of information that we really need to have and continue to explore. Also, I think many of you are aware, especially when we're thinking about younger people, that we have seen a huge increase in fentanyl being pressed into pills, into medications, and also into pills that are not being marketed as opioids. So we're seeing fentanyl being pressed into pills that are being sold on the internet as Adderall or as Xanax. These are pills that people may be buying to try to treat mental health disorders as opposed to actually looking for an opioid, and they can have fatal doses of fentanyl. So again, from a CDC, working with the health departments, thinking about policy, the ways that the threat changes is one of our most important things to keep track of. This is a slide just showing the increase in fentanyl seized by law enforcement with pills. So in 2023, more than 115 million pills seized by law enforcement, and 49% of the illicit fentanyl seizures in 2023 actually related to pills. So an example, again, of the way this continues to change. What are we doing on the ground with your states and locals around this? Our flagship program is called Overdose Data to Action. 49 states and DC get the funding at the state health department level, and then in addition, the states that you see split there, we fund at least one local health department in addition. So 90 health departments overall. If anybody from North Dakota would like Overdose Data to Action funding, come and talk to me. We'd love to take your application. But this is $280 million annually, and this is the infrastructure, honestly, that has been a big part of us getting ahead of this on a data level, and then thinking about how is the data varying across the country, how are we tailoring our interventions to the changing threat, and then working to stay ahead of it. And so what does that look like? In Chicago, which is where I spent my time before coming to CDC, we were one of the earliest recipients of the first Overdose Data to Action grant. And before we had that funding, we were counting overdoses. That's about what we were doing. With the funding coming into place, we were able to work with our medical examiners, work with our hospitals, get the sort of testing in place, work with the police departments, work with the EMS to make sure that we had data systems so we could very quickly identify when we were seeing issues on the ground. With policy, working with the police department, for example, starting a diversion program if people were arrested for possession, and saying instead of going into the criminal justice system, would you be interested in going into treatment? Evaluating those sorts of pilots, saying in the first 900 people in our diversion program, yes, they had good engagement in substance use treatment, but more importantly, they were 44% less likely to be re-arrested down the line. Working across partnerships, standing up ways that are focused outside of clinic walls, right? Public health is not directly funding the treatment, usually. SAMHSA, HRSA at the federal level funding your treatment. CDC, public health, about what are we doing to complement that work outside clinic walls. This looks different in every part of the country, but amazing innovation here. We work to evaluate then that across the country, lift it up so that something that's working in Arkansas, can be tried in Michigan. On the ground, our Overdose Data to Action recipients are also very focused on that linkage to care piece. All around the country, as you know, there have been some really innovative work to follow up after non-fatal overdoses. Even if you don't find the person after the non-fatal overdose, boy, do you find a lot of people who were just concerned the day before, maybe just had to administer naloxone or didn't even have it available. There are often family members, there are community members who may need treatment themselves, who are in the places where we want to help people get connected. So just in 6 months, our Overdose Data to Action recipients linked more than 111,000 of these very high-risk individuals to life-saving care. Obviously, we're also a big part of that naloxone distribution in a very Data to Action grants look at state or a local level, things like what percentage of my overdose deaths are coming from people who were recently released from incarceration? Is that higher or lower than the national average? What percentage of my overdose deaths are occurring in situations where there was somebody present and no naloxone administered? Opportunities for working on naloxone. So the goal is not just to count the problem. The goal is to say, how is it different in my community? How do I put my focus where the impact will be greatest? And then how do I share that so that we are recognizing who's falling behind, who's leading the way, and sharing those messages. I also briefly wanted to mention the overdose response strategy. This has been a really important policy approach. It's been about pairing public safety and public health in the whole country. So CDC funds connecting a public health analyst and then a drug intelligence officer from the high-intensity drug trafficking area. They are working full-time on that data sharing piece, protecting privacy, but making sure that when we see something emerge on the health side, we can use that data anonymously to better understand how the drugs may be being trafficked. to better understand where there have been interventions on the public safety side or opportunities with corrections and others to meet people where they are. How do we work on this in a really combined and collaborative way? It's been a very effective collaboration. And then finally, I wanted to mention the Drug-Free Communities Program. If you're not aware of this one, CDC funds more than 750 communities around the country directly. The majority in rural areas. There are more than 35 here in Massachusetts, for example. And it's not a lot of money. It's $125,000 a year, but for 10 years, specifically to build the coalition work for youth substance use prevention. So it's a requirement of pulling in youth themselves and their families, the schools, faith leaders, business leaders, health leaders, you name it. You create these coalitions, and then we help do the evaluation to know, again, what's working in the primary prevention space. And happy to talk more about that with anyone who's interested. We can't talk about substance use, especially in young people, though, without also talking about mental health. And I just wanted to highlight that we believe these are intertwined. We believe that tackling them together at all ages, but especially for our young people, is important. This is from that same survey. We do have 20%, 1 in 5 of our high school students saying that they seriously considered attempting suicide in the last year. And we have 9%, 1 in 10, saying that they actually attempted it. That, though, if you look, those numbers, they've gotten somewhat worse, but they've actually been there for around a decade. So there's a lot to explore here. Having a data-driven approach that is local and based on intervention, we believe strongly at CDC that we can be making the same kinds of improvements, incrementally but real, on suicide as we are on overdose. There's another QR code here. If you're interested, we've just put up a new mental health data channel that pulls together a lot of the more local information that we have about everything related to mental health. And we have a youth substance use campaign that's actually just launching this week, developed with and by youth. It's a video game related situation. You can see on the bottom right there, beware of the fake and switch. That's about the pills. It's really about continuing to evolve. Your health departments will have this. You're welcome to adopt it, but doing some of the continued education is important. And finally, the Trump administration's drug policy priorities are absolutely where we need to be as a country. The White House on April 1st, 2025, released this. If you haven't looked at this document, please do. Statement of drug policy priorities, there are 6. And I highlighted the 3 that are where public health really our bread and butter is. Reducing the number of overdose fatalities with a focus on fentanyl, preventing drug use before it starts, and then innovating in research and data to support drug control strategies. The public health work is critical for 2 and 3, securing the global supply chain and stopping the flow of drugs from an information perspective, but we don't directly do that work. And then in 5, again, public health is not traditionally providing a lot of the direct treatment, but we're helping to link people. And with that, I have a QR code if you'd like to see more about what the Injury Center funds in your state. Thank you again for all of your work. This is progress, but this is progress that we cannot stop now, right? We can't say this is solved. President Trump declared the overdose crisis to be a public health emergency back in 2017. That's what brought resources. That's what brought overdose data to action. We have been building on that. Secretary Kennedy just re-upped the public health emergency recently, and we are in an emergency here while we're making progress. Thank you again for everything you're doing. Really looking forward to getting to know you more.
Dr. Arty, thank you for that. Like I said, good news finally, but obviously some work still to be done. And on that note, I would like to bring in our 2 legislators on the panel. Delegate Rohrbach and Senator Sear, Dr. Arty just shared the promising national statistics, but in both of your states, overdose deaths actually declined more than 30%. What are some legislative successes you think have contributed to these declines? And Delegate Rohrbach, I think I'll start with you if that's all right.
Certainly. And thank everyone for attending. When we started down this road, and this was kind of the reason I ran for our legislature in 2014, I felt very strongly, and really, I'm going to put a shameless plug in for NCSL. Their help is invaluable. It has been to my state, and I'm sure it has been to yours. I look at Charlie, Kate, Carmen, some of the people in this room. The fellowships that I've done have been invaluable. So some of the ways we looked at it in West Virginia, we broke it into 4 silos. They're not terribly mutually exclusive, but I'll give you 4 to think about. Prevention, treatment, judiciary/law enforcement, and harm reduction. Now, I'm going to give you a couple under each of those that I think have been helpful. And one thing we've learned, it's not a race, it's a marathon. So I look back, when Charlie asked me this question, some of the things that we really put in place 5 years ago, 4 years ago, I think are really starting to bear fruit. Prevention. I'm convinced the most important thing we did was a K through 12 drug awareness program. So we kind of were onto that before CDC was onto it. But it's not the old, say no to drugs. It kind of targets kids where they're at. And with an age-appropriate message, pulling in people from the community. Very little of it's done by the school. It's at the school. Very little of it's done by the school. I guess the other thing was the Opioid Reduction Act, which kind of was like whack-a-mole. We did away with the pill mills, which were rampant in West Virginia, and then people went to other things. Treatment, I'm convinced the best thing we did besides funding treatment was our rapid response teams that went out and went to people when they'd had a non-fatal overdose, check on the home and just offer them treatment. Go to them, offer them treatment, offer them help. Realize that there are people, they're obviously not in a good place. What can I do to help you in a non-judgmental way? Judicial/law enforcement, one of the most important things we've done is drug court. And if your state doesn't have one, I'm going to urge you to do it. And if you want a real tearjerker, you go to a drug court graduation ceremony and you'll realize that people that complete that program, it changes their lives. It changes the trajectory of their lives. The other thing is we created something called the Jobs and Hope program, which it's kind of an extension of drug court, but you get job training, because I'm firmly convinced, I don't care what type of treatment you do, if you can't get a job and maintain a decent lifestyle when you get out, you're going to fail most often. So it also has some inducements for employers to employ people. So we get them skills, we cover some of the wage base and the training. We do all the training, but the drug testing for an employer, and that's another one. You go to one of those graduations, you'll see people that have changed. And the inducement in that is expungement for nonviolent felonies. Lastly, harm reduction. I think fentanyl test strips have been terribly helpful. And then all the things we've done with naloxone over the counter and naloxone for first responders. So those are the things that we've done that I think are really starting to bear fruit.
Is that it? Senator Sear, same question.
Good morning, everyone, and I hope you're all having fun in Boston and Massachusetts. This has been a gauntlet of a conference, but really thank you to NCSL for coming to Massachusetts and inviting me to participate in this. So my name is Julian Sear. I represent Cape Cod, Martha's Vineyard, Nantucket. Right now, this time of year, right, busy places, but these are geographically isolated communities, who really struggle with employment, have a lot of real challenges. And this has been a challenge for us, as Delegate Roebuck was saying, really since the 2010s, early 2010s, and really trying to get ahead of this. And we've done a number of the strategies. I think every single strategy that he discussed, we have done here in Massachusetts. But I think we've really tried to bring out-of-the-box thinking to this. First and foremost, on the broader issue of behavioral health, if you don't have robust access to behavioral health care in your state, that is going to be a major barrier to most anything you want to do. In Massachusetts, we led pretty substantial mental health reform. This is not about mental health parity, but if you want to talk to me about that later, I'm glad to. But this was really, I think, part of the bedrock in ensuring that we have coverage, yes, for SUD, but more broadly around behavioral health, and that's really been critical. And the Massachusetts ABC Mental Health ABC Act is among the strongest parity laws in the country, with a whole list of other goodies that are in it. But I think what we've tried to also bring to this is a real harm reduction framework and a real out-of-the-box thinking. I think the interventions that we have brought in the past, whether it was the DARE program that the kids from the 1990s sort of suffered through and was completely ineffective, or a whole host of other thinking, right, where we effectively sort of demonize those who are using drugs has just not been effective. And so what Massachusetts has done, we've done a lot of things, but I think first and foremost is bringing a harm reduction framework to the work that we're doing, that we're going to understand that we're going to meet people where they are. How do we bring services to where they are? How do we look at strategies related to drug testing, right? Not only fentanyl test strips, but enabling drug testing of drug supplies. In a law that we passed a series of laws, the most recent one in 2024, legalizes drug checking and provides legal protections using our Good Samaritan law for the providers who are doing that, right? So we know if people are going to be using, let's actually understand what is in, what is in the drugs, right? And we know that's certainly not heroin. It's often not just fentanyl, right? We have a real polysubstance crisis here. And then a whole host of other interventions and strategies from licensing recovery coaches and requiring insurance coverage, reforming referrals to our foster care system, mandating insurance coverage for opioid reversal drugs, mandating our hospitals that they have to educate and distribute around, basically distribute naloxone, opioid reversal drugs when someone comes into the ED with a non-fatal overdose, requiring our pharmacies in high-need areas to also provide opioid reversal medications free of charge, a whole list of insurance reforms in addition to parity related to covering pain management, that is including non-opioid options. It's been very difficult to get those options included. And then I think MAT has been a critical cornerstone to our intervention here in Massachusetts. And we have been agnostic around which MAT someone wants to use, right? I think sort of historically, there was sort of preference for one or not the other. And I think we've really tried to ensure that MAT coverage is included from, yes, an insurance perspective, but particularly in our correctional system, in our jails and prisons, requiring that that all three options of MAT is provided, and then making sure that you have a system and program that is actually making sure that when folks re-enter, they're not just sort of, they're able to continue to receive that care. So there's a whole sort of laundry list of other sort of policies that we brought to bear here. A lot of this work, a lot of credit, needs to be shared. Senator Cindy Friedman, Senator John Velas have really led this in Massachusetts, Senator Brennan Crichton as well. In the House, Adrian Motto is the longtime chair, and before him, Representative Marjorie Decker. These have been really kind of key people here. But, I think the concept that a non-fatal overdose is an opportunity is a really sort of wise framing, and I think we've really tried to bring that harm reduction approach and really to make this all about saving lives, right? Because if we're unable to save lives, if we're unable to sort of seize the opportunity of that non-fatal overdose to provide care, to provide support, and to meet people, we're just going to continue to see an unacceptable number of deaths and adverse effects in people's lives. Yes, we welcome the 10% reduction in fatal overdoses here in Massachusetts, but we've got a heck of a lot more work to do.
Delegate, Senator, thank you for that. I think my takeaway there is not only that maybe there's not a one sort of approach that we need to be taking on this, right? There's quite a bit of ground that we need to be covering and thinking about here, but also that it is very much an iterative process and that we've been making sort of dents at this since it became an issue here. And Dr. Arwady, I think I'll put this question to you on that note. What is one way you're thinking about overdose prevention or substance misuse prevention has changed, or something that you have learned as part of working on this issue?
Sure. So I'm a physician, and all of my early training was actually in infectious disease response. That's what people usually think of when you think of public health, your measles response, et cetera. What I really came to learn over the long time of working on this is that this topic needs the same approach. That actually the urgency of it, the need to have the understanding of that shifting threat and shifting response, the need to be ahead in a preparedness kind of way, and to have not just data, but then data being used by partners, by legislators, and making sure that never can health topics be tackled in a vacuum, but on this topic in particular, I think, if you are not working across your sectors, if you are not thinking about how to deliver not just for health, but for correctional outcomes or cost outcomes or the recovery home piece, you're going to miss the spectrum. We learned a lot about HIV, right? About how to think about that continuum of care, how to know where we're missing people, how to focus where we need to. This topic, I really have learned and believe deserves the same kind of hyper-focused approach.
Great, thank you. Delegate, I'll turn to you next.
Well, the first thing, and I did stumble through medical school a long, long time ago, you have to think about this as a medical problem. And if you do that and look at the data, you'll get at the solutions. But you can't be judgmental. You've got to treat it like a medical problem, because for those folks, that's the number one problem that most of them have. So you've got to look at it from that angle and study the data, work collaboratively, and the solutions they'll come. And I think we're starting to see that. There's an awful lot of people that have shared things at meetings just like this from across the country, and we've all taken it back to our jurisdictions, and I think we are starting to see some results. I know we are. There's more work to be done, as my friend from Massachusetts said. You better believe it. Absolutely. But it's treating it as a medical problem and going forward with those type of solutions that involve those four pillars. We'll get there. I'm firmly convinced of that.
Thank you. And Senator?
I think meeting people where they are, which is sort of, I think, a similar way of framing this almost as a medical issue as well. Whatever you need to do to kind of get your head around this, right? Whether approaching it as a medical issue or meeting people where they are. The other piece I think is really kind of critical is looking for, who are the scrappy innovators and the disruptors in the health delivery space. Dr. Arterway was talking about, all these lessons that were learned in the HIV/AIDS epidemic, right? So many of these harm reduction strategies come right from that. And I think we've actually really figured out a tremendous amount of success in intervening. And I can speak to that as a gay man, right? And how HIV has moved from a death sentence to now a manageable chronic condition. And that has been, in part, not just the medicalized kind of piece of this, but also because of harm reduction and a whole host of strategies that made it a whole lot of sense. And I think we need to continue to bring that framework, right? Here in Massachusetts, we're trying to figure out, all right, how else do we meet people where they are, right? We're doing drug checking. I think there's a real desire and there's a whole host of support around looking at how do we have safer spaces for people to use these drugs? How do you have those and find those opportunities, right? And so this is just, I think, what's absolutely critical here is looking at just how do you meet people and who are the folks in your state who are doing, scrappy innovation, who are doing a little bit of disruptive work that actually may end up not only saving lives, but a whole host of other crucial benefits, related to reducing ED visits, all of the EMT and first responder related, work that goes in to responding when you have overdoses, the cost savings that exist there. And so that's where I think we're really kind of keen to focus on, is just continuing this harm reduction framework, and how do we really bring that to bear, and not just sort of rest on our laurels and feeling good about, okay, we're down 10%. But I can tell you in my district, we've got like a ways to go. And so I think that's sort of the framing that I'm trying to bring to this work.
Great, thank you. And so to make sure we have enough time for Q&A here at the end, rapid fire round. And Senator Sear, not to put you back on the spot, but we'll start with your side of the dais for this final question. Moving forward, what are some of the policy changes you are prioritizing?
So we're trying to prioritize and trying to, again, figure this out in a bit of a new environment here. But how would you realize opiate overdose prevention centers, self-consumption centers? There's a whole host of names for these. Rhode Island is successfully doing this and has really good data around this. New York City is successfully doing this. I've been to overdose prevention sites in Portugal as well and seen how this works. And this includes not only just injection drugs, but smoking, which we see as an increasing way that people are using in this polysubstance epidemic. So we're trying to think about this sort of broadly, not only just having having a center or centers, which may kind of run us into trouble with our U.S. attorney currently, but how do you provide liability protections for providers? How can local governments, their local boards of health, sort of innovate here or provide harm reduction strategies? In Massachusetts, I know, tiny little state from most of your perspectives, we have 351 distinct municipalities, each with their own health authority and zoning and land use authority. It's kind of, it's not efficient, but some of them really want to innovate in this space, right? The city of Somerville is like so hungry to sort of innovate in this space. So I think we're trying to figure out really that, right? How do you bring this next stage of harm reduction, which we know from a data perspective works, we know is meeting people where they are. I think the reality is that this is also happening. We know that there are user sort of led and run spaces where people are using safely and attempting to use safely. And so I think trying to figure out how do we all be honest about that within our sort of broader sort of healthcare delivery systems. But I think that's sort of the next piece of where we want to go. Figuring out how do we do that is a needle we're trying to thread right now. But I think from a data perspective and an intervention perspective, has a lot of promise.
One of the things that I know every state and jurisdiction and territory here has done, we've all spent significant public resources on this problem. And I think we're far enough into this, and now we're starting to get data. I think part of the next phase is going to be to use results. There's no use to get the data if we don't use the results. What treatment programs are working? What ones are not? I think we all want to be good stewards of the taxpayer's dollar and get results. And in this industry, I think we're starting to see there are some operators that are maybe less than adequate, and some are doing a very good job. So we need to really start to drill down to effective strategies that are proven to work, the data's there, make them show data, and then let's fund what's working.
And Dr. Arwady, anything you can share about the Injury Center or CDC's priorities in this area moving forward?
Yeah, I think just, in terms of both meeting folks where they are and thinking about some of this evaluation data work, you heard me say strongly that this is a public health emergency, and we believe strongly that public health belongs in this space, and making sure that at CDC we're doing everything we can to have data faster, more local, more action-oriented, and more available to the public. So you don't need to be an epidemiologist or dig through 17 levels to know what is happening in your community and how to intervene. And I think meeting people where they are, it's partly about people who may be using drugs. It is also recognizing there is nobody in this country that has not been touched by this problem. And there is nobody in this country, no matter what their background is, what their politics are, what state they live in, that doesn't care about this, and recognizing that this is an area of common ground for us as a country, continuing to think about how we build on this together and then evaluate to the point what works. We're releasing hopefully next month, an updated review of everything for youth substance use prevention. What actually has evidence behind it that works, what evidence has not worked, helping us at a time when everybody is needing to pull back on resources and we can't lose this progress, really trying to hone in on the evidence and the science and the experience that has been hard-won across the country so that we're everywhere we're using local data and we're using the lessons learned in other places, and so we keep seeing that decline even when there's a lot of other things going on.
All right, as we transition into our Q&A session, if everyone would just thank our panelists just once again for sharing their insights, their expertise, their experience with us. And I think we have time, or can make time for 2 or 3 questions. You'll notice that there are microphones right there towards the middle of the room and right there towards the middle of the room. And I apologize if we don't get to everyone in this session. Again, I do want to plug that we will have some office hours with Dr. Arwady immediately following this. We'll start over here and then we'll go over to this microphone. Go for it, please, yes.
Okay, thank you very much. So I'm State Senator Deborah Altshuler from New Hampshire, and we have had just a devastating, devastating opioid addiction in our state, and have had multiple lawsuits. And you're right, there's not a single person in the state of New Hampshire, and there's 1.3 million of us, who haven't been touched by addiction in our state. And one of the things that was really helpful was the Support Act, which brought really, really necessary federal dollars in, because we put a lot of investment into community mental health services and substance use disorder services, and doing that integration work so that they weren't siloed. That act hasn't been renewed. And as much as I'm thrilled to hear that the president is communicating to the CDC that it is a priority, the fact of the matter is he had an executive order that clawed back millions of dollars. And that's hit our state incredibly hard. We can't do prevention education, harm reduction, and substance use, addressing substance use disorders without money. It just, volunteers only go so far. Doctors need money. Public health professionals need to be paid. And without this funding, and we need checks, not just words from the administration. And I hope that you'll use your position to encourage the White House to restore that funding and to retract that executive order that threw all the burden of substance use disorder and blame it on homelessness. So I think that there's a disconnect between the work you're doing and what you're telling us the administration is telling you and what we're seeing on the ground in our states. So I just wanted to make sure that we level set, and we can be innovative and creative and out of the box, but you can't do it until you pay people to do it. So thank you.
Yeah, so I would just like to say I 100% agree with you that we need resources for this, that the declaration of the public health emergency means that this is an emergency, this is a topic that needs focus, that needs resources, and a lot of what we've been doing with the new administration is making sure they have a good understanding of why we are making progress as a country, that now is not the time to take our foot off the gas with an ongoing public health emergency, and that, all of you in all of your states have seen the need and have recognized how important this funding is. And so, we really, I represent the administration, but the administration considers this a priority, and we would love to continue to partner with states to make sure that we can do everything we can so that this remains a topic that gets the funding, the attention, and the scientific backing that it needs.
Go right
Yep,
over here.
Representative Valerie Jones-Geltner from Delaware. Quick question on the data. When you use opioid use as a comorbidity instead of the primary cause of death, does data still look the same as far as the trends down, or what's it look like?
Yeah, so great question. So this is really, if it is considered the cause of death, the number one cause of death on death certificates, we do have quite a lot of additional data that looks at the combination, but quite often, overdoses, this does end up being coded as the primary, so it's not a huge amount of difference. I think there's more when you look actually at the intersections between an overdose and what may or may not be happening related to mental health disorders. I think that's when there's more opportunity for kind of understanding points of intervention, but particularly with just how much more deadly the drug supply has become, this really is about, first and foremost, unfortunately, actual overdose driven first by that use of substance at that moment in terms of deaths.
All right, I think we've got time for 2 more questions. I apologize to everyone else in line, so we'll go here and then back to this microphone.
Hi, good afternoon. My name is Julie Radoslavich, and I'm log from the state of New Mexico. Just a quick question, opioid settlement dollars. Is CDC tracking dollars that's going to states, city, counties, and if so, how can we get that data. Thank you.
Yeah, so because the settlements are directly, as you know, with the states, with the localities, et cetera, we don't have a formal role in doing that. That said, certainly informally, we've been working very hard with our funded recipients, the Overdose Data to Action, the drug-free communities, the overdose response strategy, et cetera, to make sure that those public health needs, as much as possible, are supported in the state and local level conversations about how those settlement dollars are being used. NCSL and others I know are working to sort of make sure that there are lessons learned about that, but I will tell you there is a lot of variability in how those settlement dollars, as you know, are being used, and making sure that there is that space, in my opinion, for some of the prevention and community-based work of public health remains important. So we are more in an informal kind of way, helping to support, and it really is at the state level that those decisions are made.
Just adding real quick, I think for the lawmakers in the room, it's really important for us to stay on sort of tracking where this has gone. In Massachusetts, again, part of this money has gone to 351 municipalities, some of which are doing fabulous things with it, others of which are, buying things that I think are not sort of intended here. So just staying on that and staying really vigilant, but I think it's a state-by-state level thing that we have to do. And the other lesson here, right, is that I know in our state, we had, decades ago, very significant tobacco settlement dollars that actually we had used initially for very substantial youth prevention efforts of a whole host of health related in schools. At one point during a fiscal tight crisis, we actually took those settlement dollars and ended up directing them to our general fund. So I think as lawmakers who really care about not only this issue, but broader public health, we really got to stay vigilant on it and not sort of forget it. It's easy to sort of check the box on a given bill or policy and move on to the next big thing. But I know here in Massachusetts, I keep on reminding myself, like, okay, got to track what this is doing. I'm trying to get involved even in my towns, just saying, hey, look, how are we spending these dollars? So just that's a tip from me.
And I think I'll get back to fund what's working. If we all as policymakers keep the eye on the money, but make sure it's going to proven strategies, we'll get there. So that's I guess, the thing we've learned.
We'll go over here for our last question.
Hi, Khadijah Lawal from the Joint Commission on Healthcare at the Virginia General Assembly. I was wondering if y'all had faced any challenges in licensing coaches. In Virginia, one of the policy options that we're looking at is like improving licensing requirements for peer recovery specialists. These individuals typically have like more interaction with the criminal legal system, and so often it prevents them from actually serving and being hired as peer recovery specialists. So just wondering if you've had any challenges similar to that and how you've approached those issues.
I'm gonna try. Did you guys do this? Yeah. So we did this here in Massachusetts, and we basically established this it was sort of signed into law at the end of 2024. So we're very much in the midst of sort of establishing the licensure. There is the recovery coach sort of profession is a little more sort of well-defined and sort of fits more nicely into a licensure box. Initially, we had actually worked to also include peer specialists from a broader sort of behavioral health perspective, and that had gotten kind of a little too broad. So where we landed on it was basically allowing licensure of recovery coaches and then giving our Department of Public Health, which is our licensing authority here in Massachusetts, the ability to have other sort of peer specialist related certifications that can help there. But this is really key. If peers and recovery coaches are not licensed, then they can't be reimbursed or paid through your health insurance system. So this is actually something that one of the things that we probably should have done a long time ago. I mean, I'll be honest, sort of COVID-19 kind of derailed a whole host of policy initiatives we were working on, this included, right? And so I think it's something that I think we're very excited about. It's going to be coming online pretty soon. But the navigating the difference between the recovery coaches and the peer specialists can be a bit thorny, and I'd urge you to, sink your teeth into it and figure it out how that plays out in a Virginia-specific context.
Thank you.
All right. With that, I want to thank all of you for being a great audience and for being engaged and asking great questions. Thank our panelists again for wonderful presentations and commentary. Again, if you're interested in a deeper dive with Dr. Ardy, we'll be meeting in room 109 in just 5 minutes. So that's 109 in 5 minutes. And real quickly, I want to thank the National Center for Injury Prevention and Control for their support of this session.